We have a instruction course on complications in cataract surgery. The chairperson of this course is Dr. Satanshu Mathur. So he'll be arriving soon. And I'm Dr. Rajendra Prasad, and with me here, Dr. M. Nivin. So we'll be starting the session with the first speaker being Dr. M. Nivin. Dr. M. Nivin is going to talk on zonular dialysis, prevention and management of and no capsular support.
That side, huh? Sir, कौन सा है? Yeah. Just make it full screen. Huh? Okay. So thank you, sir. So respected teachers, senior ophthalmologist, my dear friends, I'm Dr. Nivian from Chennai, and I'm going to talk about zonal dialysis management. So as you all know, to just make it simple and for learning thing, it can be graded into 3 grades. The mild, where you have up to 3 clock hours of zonal dialysis, or the moderate, when you have more, or 3 to 6 clock hours of zonal dialysis, or up to 180 degrees, and then severe when it is more than 180 degrees or 270 degrees of subluxation. So why it's important is the things that you use like a CTR or a CTS, so or you go to fix the bag, the techniques might vary depending on the degree of dialysis. So there are some cardinal signs that you might notice sometimes intraoperatively that gives you a clue that the zonules are weak. Yes, when you have pseudo exfoliation, hard cataracts, there is always a risk of the zonules being weak. The second thing is when you're doing the rexes, sometimes you'll see wrinkling of the anterior capsule. So when there's a wrinkling of the anterior capsule when you're doing rexes, you know that the zonules are weak. And then during phacoemulsification, sometimes you notice that there is undue movement of the nucleus. There is something that is not the usual. So any of these signs should give you a reason that there could be some zonular weakness. And the third thing is sometimes you can see even the bulging of the iris. So sometimes during this zonular dialysis, the vitreous tends to prolapse to that area, and sometimes you see some irregular shallowing of the anterior chamber that happens at that area. So these are some of the, let's just go through a couple of case scenarios. The first one I'm going to show is a case of mild 3 clock hours zonular dialysis, which is very commonly seen in colobomatous eyes. So as you can see here, see these colobomatous eyes sometimes pose a challenge because the eyeballs are small and sometimes you get a harder cataract than expected. So getting the rexes for any of the cataract cases is very ideal. So make sure your rexes size is slightly smaller than 5.5. The reason being nowadays is in these types of cases, if you want to do an optic capture or you want to keep the lens in the sulcus, it is a great idea. So just make it 4.5 or 5 millimeter rexes. And then initial days, what I used to do is any of these complicated cases, I used to make a limbal incision like this, a 3-planar incision, rather than making a purely corneal incision, because you expect some complications, and sometimes when you want to convert, you don't want to extend the cornea and put sutures. So I prefer a limbal based incision in these cases. A slow, gentle hydrodissection, because you should see the wave. You don't have to be in a hurry. It's because these cases you have to treat it little differently from the routine cases. The choice of phaco is depending upon the surgeon's comfort. There is no literature saying that stop and chop is better or direct chop is better. The basic principle is you should have less stress on the zonules when you do these chopping maneuvers, and usually we do the phacoemulsification in the bag area, but in these cases I like to bring the nucleus slightly forward into the anterior chamber and then do again less stress on the zonules into the bag. The third thing is, even in these cases I treat them like a case when you have a rupture, that don't remove the phaco probe, because when you have this ZD, when the AC collapses, that is when the hyaloid tends to break sometimes and the vitreous tends to prolapse. So always make sure that the anterior chamber is well formed, keep it viscoelastic. And then the cortex, yes, the third thing, I call this as a cortical stripping. So again what happens is you engage those anterior cortical fibers in the uh, aspiration cannula, strip it to the center, and then once it comes to the center, then you aspirate. So basically again I'm not pulling, because I've had cases where you think you have done the phaco and everything is over, but at last when you're doing the IA you pull more of the bag and then the whole scenario changes. So in this case, as I said, first we just showing how the placement of the CTR. So relatively simple. It is just that you should make sure and keep watching that the leading haptic goes into the bag, because we know once it slips outside it is very difficult. Sir, welcome. Very difficult to get it again. So keep an eye always on this. In this particular technique I use the dialer to put it in the inlet hole, and again make sure it goes into the capsular bag and then release the hand. You can also use the forceps, which I am going to show in your subsequent videos. So once you have, in these cases, I think a single piece foldable lens can be done well into the bag. And the last thing is, again we like to place the haptics where you have those weak areas. So that again acts and stretches the bag and prevents further contracture and phimosis of the bag. And this was a small defect, so we did not repair the iris. So moving on to the second this thing where you have a more larger ZD, and we'll also show you how you can use this thing. There was another paper published by the Agarwal group about how vitrectomy assists in phacoemulsification in these kinds of ZD cases. The basic principle is, when we are doing phacoemulsification, there is this weak area of the ZD. So sometimes this hydration fluid goes back and hydrates the vitreous. So that is when sometimes in these cases suddenly you see there is some shallowing of the anterior chamber, because there is vitreous thrust that is pushing up, and then everything starts becoming difficult. So what they have proposed is a mild vitrectomy that can be done to decompress this vitreous in cases when you have a large ZD. When you know when you're doing phaco, there is going to be some amount of fluid that goes back into the eye. So here we have used the iris hooks to have a good visualization. This also helps to know the extent of the ZD, because sometimes you see a ZD on a slit lamp and that is totally different from what you see on table. So in any case of doubts, use the hooks. Again, centration, as you can see those folds, because wherever there is no zonules, there is no counter traction. So that is the reason why doing a rexis is also challenging in these cases. So just stabilizing the bag by using a capsular hook, and again a gentle hydrodissection just to loosen out the nucleus. So this is the trocar. I think even anterior segment surgeons can start doing the trocar assisted vitrectomy. There are a lot of wet labs, and we have the man who's actually initiated the wet labs, Dr. Santanshu sir. So we have a lot of wet labs to show you how a trocar can be done, and anterior vitrectomy can be done through the pars plana approach. So basically it compresses the vitreous. So this is not only for colobomatous cases. Wherever you see there's mild vitreous prolapse or there is a gap where in these ZD cases. So once you do that, phaco becomes very nice. You have a nice chamber. The only thing again is you should make sure your bottle height is lowered, and because sometimes it can what you see in these myopic eyes, it suddenly shallows, and that can also cause a rupture. So first case bimanual, this case coaxial, but the principles of the IA will still remain the same. So now you have a nice good rexis, and you can see now we're going to place the CTR again. So in this particular thing, just showing how we can use the forceps. So bimanually you can guide it and make sure this time it did not go. So again re-grasp it and make sure it goes into the bag. So again inflate the bag, and 3-piece lenses in this is ideal, because later on if some dislocation happens, so that was the theory behind that, so you can always refix these 3-piece lenses. But the newer teaching nowadays is you can also do an optic capture that is more stable in these types of cases where you have a weak bag. So in this particular case, as you can see, the iris defect of the coloboma compared to the first case was larger. So in this particular case, we did the single pass 4th row pupilloplasty also to reconstruct the iris. So it's a relatively simple procedure. As you can see, cosmetically also it is patient better, but also when you have a smaller pupil, it also decreases the corneal aberrations that is caused and improves the visual acuity. So moving on to the next, the use of the CTS segments. So far we finished 2 scenarios where we use the CTR. So CTS segments, yes, as you can see, there is always a debate when to place the CTR. So sometimes you will have to take the judgment whether you want to place it in the initial stages, or sometimes you want to do it in the after doing the removal of the nucleus. The only difference is they say sometimes aspiration of the cortex is difficult, but I think with practice the only trick I could say is, instead of pulling the cortex, you do a sweeping movement, so that makes it easier to remove the cortex. So you just make a scleral flap, or you can make a groove or a Hoffman's pocket. So wherever the area behind the zonular dialysis, so we're just passing this particular case we use the 90 proline sutures, the double arm sutures. So the second thing is threaded through the eyelets of the CTS segment. So there are various methods and various things, but this was a very simple technique where you just thread it into the eyelet of the CTS, and then it is railroaded and brought outside. So you have now both the ends of the sutures outside. So now gently place it inside and position it into the bag where the area of weakness is. Again, the only trick is make sure that the eyelet is always kept above the anterocapsular margin when you tighten it, nor it should not tilt down. So that can sometimes even cause a rupture of the anterocapsule. So just position it and then tighten it. So we have the CTR and the CTS and a well stable IOL. So the different grades, and the last thing is when you don't have the entire thing is subluxated, so we are left with only one option to remove the lens and place a secondary IOL lens. So in this particular case, we make a 180-degree flaps on either side. So we are planning to do a lensectomy, vitrectomy with a secondary CMT flex IOL. So basically we make 2.5 flaps on either side and 1.5 millimeters away from the limbus. We make a 23 gauge sclerostomy. I'll just run through the video fast. Yeah. So in this particular case, we use the same sclerostomies to do the lensectomy. Since it was a soft cataract, it was easier to do the lensectomy, just making a puncture posteriorly and with good aspiration and cut rate. So this is a new single piece hydrophilic CMT flex IOL with specialized T-shaped haptics on either side. So basically the idea was when you remove these haptics through the sclerostomy, it opens up and just stays in this thing. So there is no need for tucking or suturing of these lenses. And since it is can be done through a regular cartridge through any clear corneal incision, so you just hold the T part of the lens and then inject the remaining of the lens. At this time you should not pull it because it's a single piece lens, so it can detach from the optics. So just wait and inject and leave the trailing haptic either over the iris or at the wound. So once the injection of the lens is done, you just bring it outside. You can see the pop of the T and it opens up and that stays like that. So the same thing is done on the other side using the handshake technique. Yeah, the same thing is done on the other side using the handshake technique, and it is brought out. And once it is out, because of the 180-degree marking, there is not going to be any tilt or anything, and that is literally the end of the surgery, as you can see here. So thank you.
Thank you, thank you. So this lens has been real. Now invite Dr. Ajendra Prasad. This lens has been innovated by him, and this is very. I am also using this lens. This is really very helpful in emergency time. Thank you. Now we invite Dr. Ajendra Prasad. We all know is a terminal chopper man. He has developed many new instruments, many new devices. Let us see what he is going to tell us today.
Good afternoon, and thank you, Dr. Satanshu Mathur, for giving me opportunity to speak to the audience here. So topic which I am going to talk about is saving needle microcapsulotomy, and we do not have any financial interest, and you know that these intermittent pearly white cataracts, the main problem with these cases is creation of the capsular axis, and this is primarily because of most of these cases they have a very hyperhydrated swollen lens, they have a multiple fluid pockets, there is a voluminous swollen nucleus, and anterior chamber is generally shallow. The anterior capsule is stretched out and thin, and it protruding towards anteriorly. So what happens, like when you puncture these capsule with the needle, you would get a complete volcanic eruption of the intralenticular fluid and escape of the pressure which is there inside the capsular bag. And this pressure which is released from the capsular bag, it produces a disruptive force on the edges where you have punctured it. So what happens many times when you puncture the capsule, because of these intralenticular pressure and the disruptive forces which is acting on the cut which you have made on the anterior capsule, starts extending to the periphery, and it results into a complete radial tear which is called as the Argentinian flag sign. Now this name was given by Daniel Perronet because this simulates exactly like a flag of the Argentina. So how to prevent it? You know that before we, sorry, what happened? It's gone.
Audio visual somebody? From audio visual?
Audio visual.
Next to next आप बोलो So Dr. Ayanda has developed this technique. This is a swing machine technique. This is nothing but a simple needle, but he has given the band so that it gives really 100% result in hypermature cataract. You can, Dr. Partha, please join us. You can guarantee this capsulotomy will be not Argentine sign. It will be normal capsulotomy, even the hypermature morgaginic cataract. So this simple device is costing hardly 5 or 6 rupees. They give a peace of mind. So Dr. Rajinder has developed so many things like this. Rajinder,
Yeah.
can we shift to?
बस आगे आगे एक सेकंड है बस आई जस्ट शो 2-3 more slides. हाँ ठीक हो गया एक सेकंड है यस क्या हो रहा है
Dharendra, can we start
हाँ
next?
you can start otherwise
So there's some technical defects. So we are going to next video. That is about Dr. Deepak Bagu. We all know him. We all see his videos regularly. They are really teaching videos. So Dr. Deepak Bagu, please. He will speaking of mastering skull fixated IOL. We all request you all to speakers to stick to the time, 8 minutes time.
Thank you, sir. Thank you for the opportunity. And I'll be giving a basic overview of the scleral fixated lenses and trying to share a few tips here. I think the scleral fixated IOL techniques can be divided into two major groups. The one where we suture the haptics and to the sclera. The haptics are fixed to sclera by using a suture. And the second would be a sutureless technique. In the suture technique, we were using 10-oprolin before. Now we shifted to 9-oprolin, and then nowadays we use shifting to Gore-Tex. The sutureless techniques, which Dr. Nivian has shown multiple variations, and this is the modern way of managing this. The first introduction of the concept was by Dr. Gabor Shariat, where he created an intrascleral tunnel, and the haptics were threaded into this tunnel, and that was what is fixating it. Then Dr. Amar Agarwal modified it, and the glued IOL came into existence. And the latest technique, which is very popular currently, is the Yamanese technique, wherein the haptic is cauterized to create a small bulb which goes and fixes into the sclera. And as we saw, Dr. Nivian, he has devised a new wonderful device, IOL, which is called as the T-Flex, where the T of the hydrophilic lens itself goes and holds or stabilizes the lens. So these are the common ways by which we use scleral fixated lenses, but there are certain complications which are often associated with these scleral fixated lenses. We have to understand them. Decentering and tilt is the more commoner complications which we get across. Of course, dislocation, especially when we are using 10-oprolin over a period of time, it just the lens just disappears into the vitreous cavity. Erosion of the sutures and haptics is a realistic complication, and it can cause infection, and that's what we are worried about. And vitreous hemorrhage and retinal detachment are the other complications which we need to be concerned about. Now moving on to the surgical technique, I'll be just sharing the classical sutured way of scleral fixated lenses, although we don't use it more often than nowadays, but this is what it is. Again, this is a case where a PMMA lens dislocated after many years of surgery. So it's about maybe about 10-15 years later. Now the patient is presented with a decentered lens, and I'm just going to go and take you through a few basic steps here, okay? So these eyes will be very soft. So when before entering, you have to clear the scleral tunnel and the scleral flaps itself, because the eye would be very soft once you do that. So there's a reason why because it's a PMMA lens, you have to have a 6.5 millimeter scleral tunnel to remove it, and then I'm creating those scleral flaps where we are going to bury the tie the suture and bury under it. So that also is created before opening the eye. So that's what we are trying to do, because once the eye becomes soft, it becomes extremely difficult to maneuver. So I just going to forward it a little bit. You create the flaps as has been demonstrated by Dr. Nevian. Marking this horizontal meridian is very important. That helps us to ensure that we don't have a decentration or tilt of the lens. And once the flaps are made, then we are going to enter it. And under the cover of OVD, you push back the vitreous and pull out the lens inside. And this is the time you're going to create those paracentus incisions. And one of the most important steps when you're trying to do the scleral fixated lens is, obviously here I'm doing in vitrectomy, is to fix the AC maintainer. We have to have some sort of a fluid which is going inside. Ideally, it had to be fixed before even starting the vitrectomy. That should be the best way to fix it. Because the fluid has to be going in. That's the secret of maintaining the chamber and preventing the eye from becoming extremely soft. And the double-ended Prorian suture is being used, and we are going to thread out the sutures both eyes outside, and then these sutures are going to be tied onto the hole which we have in the. These are conventional PMMA lens, which is slightly larger, which has got a hole in the aptic, and we are going to tie this suture on either end, and then it is going to be introduced inside. So this is how we are going to try both of the sutures. And nowadays we are shifted to using Gore-Tex. The only disadvantage is the cost of it, but it is definitely considered to be much more stable. And this is a critical step where you are going to ensure that the lens is reasonably centered. Both the sutures are externalized, and now we are going to use the same needle to suture it to the scleral bed so that it fixates well. So you're going to use 3-1-1 knots, which is then sutured on either side. And before tightening, we ensure that the lens is well centered so that the traction is equal on either side. Then you cut the knots in, and then the wound is closed. So until the last moment, you keep the AC maintainer, the fluid running inside. People who have done a pars plana vitrectomy, obviously they use pars plana infusion source. For anti-segment surgeons like us, that is what we use. And that was it. The conjunctiva is closed. That's it. So it is a reasonable choice. The sutured scleral fixation is also a reasonable choice when you're faced with explanting a PMMA lens. So we are forced to make a bigger incision. Otherwise, you can always resort to the newer techniques where you can manage through a smaller incision like Yamane or CMT flex. So that was it. Thank you for the opportunity.
Okay, so I'll just finish this. And so how to prevent it? So before we do something, we should know that why the capsular tear extend to the periphery. So the postulations are like it is either because of the raised interlenticular pressure, and the second important factor which comes up is the forward thrust of the nucleus on the back of the anterior capsule. And this happens when you puncture the needle, puncture the capsule, or open up the capsule with the help of the forceps. And the third important factor which we have proposed is the configuration of the initial puncture, how you puncture the anterior capsule. And as you can see, like if you puncture the anterior capsule with the help of this needle, that is hypodermic needle, which has a tip which is like a knife, sharp tip, and you puncture, it creates a linear cut on the anterior capsule. Now this linear cut is also produced when we puncture with the help of the capsulorhexis forceps. So when you are using the capsulorhexis forceps on the anterior capsule, you try to puncture or penetrate it or create a tear. Now this tear, because here also you are creating a linear cut on the anterior capsule. Now this linear cut, once you produce with the puncture or with the help of the capsulorhexis forceps, as I said, there would be a sudden upthrust of the nucleus. There would be a release of the interlenticular pressure and volcanic eruption of the fluid, which acts on this cut portion of the anterior capsule, and it starts extending to the periphery. So before starting capsulorhexis, many times we do the needle aspiration. This is the common technique which we have been using, and we have seen that many times we are successful, but quite some time the capsular axis tear extend to the periphery even after the needle aspiration. So we have several techniques. The technique which I am going to tell you here is again gone. So some problem is there. I think I just wanted to show you the last video, but I don't know. Somehow it's not working today.
So,
Their connector is not working, I think.
and can we go to next?
Okay.
So, thank you,
I
Rajendra,
think
because,
my concept, I'll just tell you just one line, like basically you should not puncture with the needle or don't tear the capsule with the help of the capsular forceps in the beginning itself. You have to decompress the bag, and decompression can be done only with the help of either you do a, चल रहा है? या तुम्हारा कुछ गड़बड़ है आज?
concept is that this needle, before they are indored, we have to decompress
So,
the cortical matter.
yeah.
Only then we should add by the capsulotomy to avoid the Argentinian sign.
So idea is like instead of making a linear tear on the anterior capsule with the help of the needle or with the help of the capsular rhexis forceps, you make a hole on the anterior capsule. Now this concept we have published in the JCRS, and this concept was selected as the best technique in the ASCRS video film festival also. And this is called as a saving needle microcapsulotomy, and this is a saving needle which we have devised. And as you can see, if you puncture the anterior capsule with the help of this saving needle, so this is the tip. As you can see, it is a round and pointed tip, and when you puncture this, the anterior capsule with this, you make a hole. So you can say this is a micro hole which is formed on the anterior capsule, and if you use the needle, you make a cut. So you can see the difference between the two puncture. One is hole, the other one is a linear cut. And you very well know that the linear cut would extend immediately or spontaneously to the periphery. But if you are making a hole on the anterior capsule, this has a very great resistance against any kind of the pressure, and it will never extend to the periphery. Thank you very much.
Thank you, Dr. Inder. So we proceed to the next talk, Dr. Partha Vishwas. We all know him, Chairman Scientific Committee for the last 3 years. And he will be speaking on a very important topic, when VFPCR, all is not lost.
Thank you very much, Satanshu sir, for giving this opportunity every year. And the dilemma happens when a posterior capsular rent takes place. So it is a chill down the spine, and but to maintain cool, calm, and to make a judicious decision is all that is required. So if you look at a meta-analysis, and it shows that the PCR in the literature reported between 0.2% to 14% in different studies, and that was one that is very important, because as now the machine, the skill of the surgeon, instrumentation, everything has improved, it is becoming even less. So, but even if it does become less, it is a reality. And with this reality in mind, let us look into what the incidence of nuclear fragments is in the vitreous cavity following a PCR is 0.3%. And when there is a nuclear fragment in the vitreous cavity, it is our retina colleagues who will have to take over and do the job. Incidence of dislocated IOL in vitreous cavity post-cataract surgery is just about 0.2 to 0.03%. So this is the reality, and let's now look at a situation when a PCR has occurred and what to do. So now, if a PCR is there and it is a small PCR, it is a PCR that is not extended immediately, vitreous has not come in, then is a PCC, a posterior capsular rhexis, possible? Meaning that the PCR, can it be converted to a posterior capsular rhexis? And let us look at the situations. So when a posterior capsular rhexis is impossible. So let us look at this particular video in which the posterior capsular rhexis is impossible because it's a very large PCR. You cannot get through with a PCR like this and do a rhexis. Sorry. And what has also occurred is there's a large chunk of heminucleus right there. So the first thing is the usage of high molecular weight viscoelastic to partition off the vitreous face from the nucleus, and at very low parameters, very, very gradually taking off the nuclear fragment, all the time pushing in viscoelastic so that the bag does not unsettle. So with this in mind, becomes important if vitreous comes in to the anterior chamber, it is important to do a vitrectomy and then go ahead to the next part, meaning removal of the cortex has to be done again, remembering in mind that the vitreous should not be pulled while the cortex is being taken in the aspiration port. And then when everything is done, the intraocular lens, and this best be a three-piece lens which goes into the sulcus, it should be placed in and it should be well centered. One needs to see that there's a good centered lens and a posterior capsular capture can be done. But last and most important is the use of triamcinolone to figure out whether there is any vitreous in the anterior chamber, and if there is any vitreous in the anterior chamber, even at this stage, anterior vitrectomy needs to be done to remove that vitreous that is there. Otherwise, the traction that goes to the periphery or to the base of the vitreous can produce breaks and tears and retina detachment as well. Now let us look at this situation when a posterior capsular rhexis is possible. And here was a patient in which we had completed everything. The nucleus was taken out, the cortical matter came out, everything was fine, and suddenly there was a PC rupture. So when this PC rupture occurred, then what we did is it did not extend. It was a central PC rupture. We inflated the bag with high molecular weight viscoelastic so that it does not escape out of the wound, and with microforceps we drew out so as to form a capsular rhexis out of this PCR. Now if this is done and if this is complete, then this bag is actually a bag that is a stable bag. You can very easily put in a single piece lens inside this bag and it will stay stable. The only thing is, of course, if the vitreous face has been disturbed, you need to check it out with triamcinolone, and that is again very, very important. Now triamcinolone has another great benefit, and the benefit is that this triamcinolone actually the next days, even if there's been a lot of manipulation in the anterior chamber, the next day's cornea is relatively clear because of the minimal of steroid that has actually coated the descendants of the endothelium. So if again this is a situation, there's a large PCR, and with this large PCR we have to take out this nucleus that there is, and each time taking out the nucleus, but what we need to do is to also fill up the anterior chamber with viscoelastic. So it's important again to see that the anterior chamber does not develop, does not have vitreous in the anterior chamber, and removal of the phaco needle should be only when there is a good fill of viscoelastic in the anterior chamber. So again, it's important to remove the cortical matter and to see how much the rupture has actually enlarged. If there is not much of a rupture enlarged, still can we actually put in a single piece lens in the bag is what is to be assessed. But even in this case, we could see that it was a very large capsular tear and this could not be done. So we place a three-piece lens inside in the sulcus in this case as well. Now let's look at the next situation, and here we have a PCR with a toric IOL, and this is actually a difficult proposition, and you can see the toric marks over there. The PCR has occurred. Now we have to see whether there is space to do a capsular excess here. So there was space and we could do a posterior capsular excess and converted this PCR into a PCC so that it becomes nice and stable, and we do not have the possibility of this rupture extending. So again, this is a very stable bag. We were lucky that it did not extend, and placing this toric lens, which is of course a single piece lens in the bag, is mandatory. And once the toric lens is placed, since there is just around PCC, one can even rotate the lens quite unharming the vitreous cavity, and this can be nicely placed in the bag and in the angle and the axis that is required. So all this of course has to be done under high molecular weight viscoelastic so that the chamber is well formed and we do not have vitreous coming into the anterior chamber. Now obviously you can see that there is a large nucleus fragment that there is. I had actually pushed that nucleus fragment out of the way, wanted to get in the intraocular lens in the bag, and now of course we can remove that little fragment either by the phacoemulsification or just removing it out through viscoexpression. Now, another situation which I do not have a video of can arise when there is a relatively large PCR, but it is a toric lens that has to be implanted. So what do we do in these cases? So there is one possibility in which there can be the lens can be placed in the sulcus. A single piece lens, toric lens, can be placed in the sulcus with a anterior capsular capture, rotating to the axis and making an anterior capsular rupture, anterior capsular cushioning, so that it goes into the anterior capsule, meaning that the haptics are there in the sulcus, but the capture is with the anterior capsule and the optic of the lens has gone behind the anterior capsule. So this is another proposition. Now the last of the two small videos that I would like to show is, can we actually place a single piece lens in the bag, even with a rupture, with a transverse rupture of the PC. So this is a typical of the posterior polar cataract. There's a big rupture of the PC, and you can see that hammock-shaped thing. Now here in this case, it is very important to realize that the leading haptic has to go right between the anterior capsule and the ruptured posterior capsule, which is hammock-shaped. Now once it gets lodged, the haptic gets lodged between the anterior capsule and the ruptured posterior capsule, it is important to place in the haptic very well so that the arm of the haptic is actually pivoted, just like as you can see now, and it goes directly into the space between the anterior capsule and the ruptured posterior capsule. So both ways to do it, not to rotate it, and the landing of the lens and the haptic has to be over the iris so that you can actually twist the arm and pivot it and place it in the bag. So this is a technique that can not always be followed. It's only to be followed if there's no vitreous, the vitreous phase is intact, and you've got a good opening with the viscoelastic between the anterior capsule and the ruptured posterior capsule. So this is the last of my videos in which we would like to show that this is a longitudinal rip. It's an eccentric longitudinal rip, a little more difficult, and once we take off the cortical matter, we understand that the arms of the rip are asymmetrical. So there's a larger arm and there's a smaller arm. But can we place in the single piece lens inside the bag? Now, it has to be, this again needs to be very, very aptly followed up, and you can see the blob of the viscoelastic going in between the ruptured posterior capsule and the anterior capsule, and again landing the lens over the iris and then closing in and then moving the haptic position so that it faces the bag, the ruptured bag where the haptics have to be placed. So we turned it around, we placed it, again the haptic goes in, and it has to go in under direct visualization in the bag, which is ruptured but which has the amount of space that has been placed with the high molecular weight viscoelastic. And after doing this, you have to test and see that it is actually in the bag. If the pupil keeps crowding, you have to make sure that it is in the bag by stretching it out at one side. Of course, triamcinolone has to be there, and so that there is no vitreous in the wound. Thank you very much for your patient hearing.
We will have discussion on this. Now we are go to the Dr. Kamal Kapoor, who will be speaking on a very important topic that is very common mistake we do, how to manage the capsular axis when it has gone wrong. We'll discuss with on Dr. Partha videos after the talks. Please stay with us.
Following up after Dada with his booming voice is kind of a tricky task, but I'll be talking about a similar subject, but yes, this time we're talking about the anterior capsule. See, whenever we talk about the posterior capsule, we all are very anxious, you know, things shouldn't go wrong with the posterior capsule. But 30% of the times the posterior capsule can go wrong because of the anterior capsule. So let's not ignore that. So I'll be talking about the oops situations of running out of the anterior capsule, which is leading to situations which can probably cause more problems for us. So you could have a situation in a hypermature cataract, a run out, your keratome perforating the anterior capsule, a run out of the capsule in a mature cataract, patient moving, a run out under the incision, and even with a femto cataract you could have a run out. You could have a sudden popping up of the Argentinian flag sign run out. So we will see all difficult situations, how to manage. I'll go very, very fast on this. The thickest part of your capsule is anything between 5 to 7 millimeters. So that should be the limitation of your capsular axis size. The trick is to keep the anterior capsule always flattened. As Dr. Satanshu said, you keep the anterior chamber totally flat with viscoelastic. So even if there is a run out, it will not run out totally. So the centrifugal forces and the total forces of the anterior chamber should be higher than the lenticular force and the vitreous force, which means you need to inflate the viscoelastic. But in case you had a peripheral run out which is touching the zonule, then overinflating can cause problems for you. So there is always a balance of the centrifugal force and the centripetal force. The centrifugal force will go up when there is less viscoelastic in the anterior chamber. So with the centrifugal force, less viscoelastic, the anterior capsule will start coming forward and the rexes will be pulled out and you will have a tear. And centrifugal forces will increase when you flatten the anterior capsule by pushing viscoelastic. So have a non-leaky wound, a good construction wound, and a good viscoelastic. Another trick how to probably achieve a situation. Now this is a situation where we've been attempting, the patient moved, we went in with a keratome, and we have a 2-cut flap here. I'll go with videos very sharp, fast. You see the flap is cut into 2. The patient moved and the 2.8 keratome moved. So we will try and understand how much of tear has happened. You will see I'm trying to engage and see, yes, it has gone to the periphery. So you should not be pushing and pulling this. If you push and pull this, you will aggravate the situation. Again, trying to see the other loop. It has gone behind the iris and it is touching the equator now. So now what do? We push in viscoelastic. I'm trying to ensure, can I do something? But I'm not able to do that because it's encroached the zonules, gone to the total complete periphery. So now I do a double slip procedure. I use a 1 Rs forceps and I create tangential cuts in these 2 flaps. 2 tangential cuts in these 2 flaps to initiate a new edge of the rexis. And once I have these 2 tangential flaps, now you will see the flap opens up. And now you can hold each edge at a time and complete your rexis. So this is a good idea. Use 1 Rs scissors to your advantage, but do not attempt it without putting good amount of viscoelastic. 99% of my surgeries are in methyl cellulose. I seldom use sodium hyaluronate. I only use it in pediatric cases. Otherwise, normally I don't. So at the most, I might use a frozen HPMC because my comfort level with HPMC is very high. So what I've done is I'm just extending the capsule bilaterally using the snip technique. And there you are. The rexis is over and the case will be completed. Now we go to a second situation. Now this is a brittle capsule. It is subincisional. What to do? It has gone peripheral. I just fast forward the video. So pulling this will be tricky. So I again use the 1 Rs to snip it. इधर पूरा video नहीं आ रहा. मेरे इसमें पूरा आ रहा है. Now can you see it? Yeah. Yeah, now can you see? I use the 1 hours to snip the tail. And once you snip the tail, you can go ahead and finish the cataract. There. Now another situation. Now this is the rexus turnout in a mature intumescent cataract. I'm showing you different situations and then we'll go to the advanced stages. Now this is about to rupture Argentinian flap sign. So we've realized that it is going to happen. We put dense viscoelastic on top and now start. Now see what is happening. There is a bubble here. The moment the bubble leaks, and see what will start happening. The bubble is leaking, so my pressure of the anterior chamber is going down and the bubble leak has caused the peripheral extension. So when you're doing viscoelastic, make sure there are no air bubbles there. Now how to manage this? Again, use the snip procedure, create a tangential cut, and now you're ready to do the surgery and complete it in a different manner. Now this is another similar situation. The rexus is run out. I'll go fast. See, it's run out. Now in this situation, creating a snip is little tricky. We'll try and peel it. It's not going, it's not tearing, it's not tearing. So what do? We create a fresh cut. We use another cystotome, create a fresh cut, hold the loop, and now bring it and complete the rexus from this side. The trick is not to leave a sharp margin of the capsule rexus. If you leave the sharp margin, you will have a peripheral extension. Now this is a traumatic case of complete torn anterior capsular rexus, iris incarceration, and this is a partially absorbed cataract. Now there's a complete already existing, I am not even sure whether it's extending to the PC, iris incarceration, torn iris, torn capsule, and partially absorbed cataract. So first we just fast forward, we suture the wound. Now there is the iris which is totally torn. Now I'm trying to investigate how much of capsule rexus runout I have. So once I've partially identified the capsule runout, see, I will use a needle to create a fresh cut there. And now I use the snip technique. I'll create a T-junction, LT junction. And once this is done, now you have two flaps in the capsule. Now you cut the snip and now you have two flaps. Now you can utilize this to complete your rexus. Once this is done, push in the lens, and after you've done that, you do the four-pass repair technique, and this is how the case will be finished. You suture the iris, and this is how the case actually, by the time it's finished, it looks like this. So using good amount of tools. Now this is a sharp edge which has been mismanaged by my associate. You will see there is a peripheral extension, but my junior surgeon has not caught it. So what happens? See, you can see the cut. He's trying to pull, probably thinks that the rexus is over, but it is not over. And when the surgery is over, you realize what has happened. There's a complete PC tear. The PC has extended and the anterior capsular tear has resulted into the posterior capsular tear. There you can see a floating flap. So if you have a peripheral extension, please don't try and tug and pull on it. It will cause problems for you. And I think now I'll just give you last few. This is a subincisional runout. Subincisional runouts are a little tricky to manage because they do not give you the space. You'll see this is a runout here. So you give a jerk. This is called a jerk technique. You hold it, pull it with a jerk, break the zonule and complete the rexus. 80% of the times you will be able to do that with this procedure. Now I'll show the last one or two videos. This is the T technique described by me many years ago. A lot of surgeons are using this. As Dr. Rajendra Prasad said, I actually use a puncture technique. So I use a 27 gauge needle, bevel bent downwards, works 100% of the times. Fill the syringe with half cc water. Don't take it with air. That will give you a lot of control. Puncture it in one go. Puncture and start aspirating. You see the fluid has started coming out. This has reduced the intralenticular pressure. Then I dip the cataract downwards with the needle, and as I come out, make sure you don't have the suction on your cannula. Now you have a straight linear cut. There is reduced intralenticular pressure. Increase the incision now to normal because you didn't want a sudden depression. Now you can use a 1 hour to create a T flap. See, I'll create a T flap. Now you have a T. Now you have two flaps. Now before you start pulling on the flap, push more viscoelastic to express the retained absorbed cataractous material behind the IOL to reduce the interlenticular pressure. And now all you need to do is just hold one of the flaps, and so beautifully you are able to manage it. So you have two flaps. So all my associate surgeons, once they join my group, I train them in all these tricky situations and make sure that they don't need to call me next time something like that happens. So the advantage of these two flaps is you can have the shape of the rexis, the size of the rexis, and the site of the rexis you want. You can maneuver it the way you want. So this is called T technique. Now reversal T technique in a situation where there is impending Argentinian flag sign. So I'm showing T technique now here. It's a high intralenticular pressure, make an incision, suddenly we realize it's going to extend out, we put in viscoelastic, and see how I use the T technique here. I will create an extra puncture and reduce the intralenticular pressure. I puncture, go underneath in that area where the cortex is pushing the capsule outwards, and I'm reducing the interlenticular pressure. Now suddenly the flaps which were opening have started closing. Once I've done that, I'm sucking all the cortex from underneath because there was a lot of pressure in that tearing area. So the T technique to the rescue again, use the vanas to create a T, and all you need to do is join these T's, and there you are. You're out of the situation. Two more videos. Dr. Sudhanshu, if you permit me. Okay, now this is another situation where the capsule rexis has run out using the T technique. Again, go there, cut, linear cut, two T flaps, join, and second flap you hold and join, and you have a complete rexis. So even in a small pupil where you could not figure out till how the capsule rexis is. Now this is another Argentinian flag sign which has happened. My associate was operating and I was called in the theater that, sir, ye to gaya, this is going to sink. So I go in, I take the stock of the situation, I do the same intralenticular pressure reduction by creating a puncture with a needle, the T technique, cutting the flap, creating a T, you can see a T flap, joining and finishing the case.
ये तो दूसरा है यार, ये नहीं दूसरा है, दूसरा लाओ.
So if you are innovative, now this is an interesting situation. This is a run out in a femto cataract. This is a very old video when I just started doing the femto. You will notice there is something going wrong. The capsule has not detached from one area. But this is probably one of my first few cases, so I didn't know that. I just go in, hold it with the capsule, and I'm so happy everything is over, and I pull out, see what happens. I create a peripheral run out with a femto cataract. So it can happen in the best of technologies. So you need to be aware of what you're doing. So I needed to pull the rexis upwards towards the endothelium of the cornea, and it would have broken and not caused this problem. But I thought I've created, I have completed the rexis and I pulled it and I caused a peripheral extension. This is last video. This is again an intumescent cataract with fibrotic capsule, femto, and it has not, the energy was not enough. So the capsule is, the rexis has not been complete by the femto machine. So don't be in a hurry. I've learned my lesson. I've done it previously. So I now do a manual completion of the rexis even in a femto cataract. There, slowly peel it, slowly, because it's a fibrotic cataract, fibrotic capsule. Use, extend it from both the sides, and slowly you complete the rexis. So I guess, Dr. Sudhanshu, that's it. I have more videos, but I'll skip it. Thank you.
Dr. Kamal Kapoor. I think that's an excellent, it's an entire encyclopedia on rexis, and there's nothing more. I think you should have a competition if anybody could show a newer technique. But there's a lot of learning and teaching, and I think you should all try it and improvise it, and we wait for the questions in the end. If any of you have questions, I know all of us had trouble with rexis. I think there's no better person. So the last speaker for the day today is our hero, Dr. Sudhanshu Mathur, who's been the chief instructor of the course, and we've been doing this course successfully for the last 5 years in all India. Yeah. So, and he's going to talk about IOL exchanges, the various methods of getting the IOL out. So over to you, Sudhanshu Mathur, and we've all been trained, and you all know about his SSTC and his interest in training and teaching everybody. So, you ready, sir?
Mal.
So what Dr. Rajendra Prasad has said, this is make a hole and then extend it. Dr. Kamal has said without extending the making hole, you can make hole with the simple 26 gauge needle, which we all are doing for last so many years. So my topic is IOL exchange, why is important. Once upon a time when we were studying, we had never thought of IOL implant because we were learning IOL implantation. That was difficult for us 30 years back. But at the time for till our practice for up to 5-6 years back, we will never thought of explanting the IOL because it was not easy job. Nowadays, everybody wants 6/6 vision. Our time was when it was there refractive error residual +3, -3, patient happy with the glasses. But now, this is not the scenario. Everybody wants 6/6 post-operatively and they are refractive surprise also. What are the indications for the IOL explantation? So their indications are, number one is the IOL power wrong calculation, unhappy patient because of the multifocal lenses, the rings, shadows, dislocation of the lens, and damage to IOL haptic during the insertion. So there are many things that causes, this is the lens, this is operated almost 30-40 years back somebody. This is totally opaque lens. Patient has 6/36 vision. I don't surprised to see even 630 how is there. So we have no option but to remove this lens. There are many techniques, but the simplest technique which we are going to show you is the scissor. This is known as IOL cutting scissor, available with all the medical labs companies here. We have to just do two things. Dislocate the lens from the back into the antechamber. Because operated 30 years, 40 years back, so there are a lot of adhesions here. We have to remove all the adhesions by the viscoelastic. You see, condition of posterior capsule, so much opacification also there. So we are removing the lens, slowly injecting viscoelastic behind the lens and over the lens. We have to protect the posterior capsule. We have to protect the cornea also. Once the lens is into the antechamber, we have to remove it. We want to remove it from the 2.8 millimeter incision without giving any stitch. If we have to enlarge the incision, no issue. So see, this is scaffold lens. We are injecting behind the opaque lens to protect the posterior capsule. This is 3-piece lens we are injecting because we don't know the condition of the posterior capsule. You have to use lot of viscoelastic to protect the endothelium and the posterior capsule. Incision is 2.8 millimeter only. Stitchless. So one instrument is holding the lens and this IOL cutting scissor is just make a cut up to the center of the lens. This is enough. Hold the lens and pull it out. The cut end which acts as a fulcrum over the incision side and you can rotate the lens and it will come out from the 2.8 millimeter incision very easily. Not to enlarge incision. Otherwise, we have to enlarge incision to up to 6 millimeter. So this lens is out. So this is the way we can manage the IOL. And already lens has been implanted, so it is okay. There's another situation which I have just talked to you is the broken haptics during the. You see, when we are injecting the lens, especially in the Indian hydrophobic lens, cartridges are not so good, so their haptic is broken with viscoelastic is less there. You see, there the haptic is broken. If you leave this haptic, lens is going to dislocate someday, और आपका colleague जो होगा बाहर से बैठा, he will say ये टूटा हुआ lens डाल दिया है. So to save yourself, you should not leave this lens inside the eye, but you should take it out. So if you leave this inside, you have taken out the haptic. If you leave the lens inside, it is going to dislocate one day, no doubt. So this is hard lens. We are just supporting with the other instrument for the side port and cutting through and through because hydrophobic lens, difficult to cut. So we have cut in 2 pieces. We will hold one piece and we will remove it. Simple forceps are there to help us to remove all the lens. In this way, you can remove the other piece also. Third case I want to show. I I want to show you a third case. This is a case, already lens implanted in this case. There is a one more technique to use, which is they are capsules technique. Previously, when we were using IOL, there was no injector. You will not believe it. This case 3. When we were doing this, started IOL, there were no injectors. So we had to have a forceps that was known as capsule holding forceps, through which we were removing the lenses. So not to cut the lens, just press by the one iris spatula from the behind the lens. From the behind the lens, we are just pushing the IOL up, so they make a fold over it. And the forceps on the two sides, they hold it, fold it, and then you can take it out from 3.2 millimeter incision. So there are different techniques, whichever you like, you can use it. But if you have IOL cutting forceps, that is more convenient. So I request all of you to have one IOL cutting forceps in your library. Thank you very much. Now I will request Dr. Kabul. We have some topics here recently, just like the anti-vitrectomy. So I would like you to comment on the vitrectomy that done by Partha Vishwas. What suggestion you will give, take home message for the vitrectomy, anti-vitrectomy by the anterior segment surgeon?
So I think there were 10 commandments. I think Partha sir covered it all. So the first important thing is anticipation. Like when something is going wrong, you should accept that something is going wrong and stop. Because most of the times when we start continuing and the small problem starts to become bigger. So first thing is stop, then don't panic. And then start to reassess and see what can be done. Having your instruments, like always having a cutter, like all anterior segment machines comes with a cutter. But unless you know it is sterile and it is always ready, you don't have to use it, but make sure it is there. And you should also know whether it's a 20 gauge or a 23 gauge. Then use of tricot assisted vitrectomy. Sir had highlighted 2 points. How much ever you see, sometimes vitreous we might miss and you might feel bad the next day when you see it on slit clamp. So always stain it with vitreous, the tricot, so that you know exactly what you are cutting. And there are studies that shows when you stain it and cut, you actually spend less time cutting because you know exactly where the vitreous is and cutting the vitreous. And some amount of vitreous helps in post-op CME, also the chances are less. So again, tricot assisted vitrectomy, making sure your machines.
What should be the dilution of the tricot? Tell the audience, please.
So I'm very bad at this because I don't actually dilute. I have a different technique. The concept is you put the tricot in the anterior chamber. So most of the times you go, when the cannula is facing down, the entire tricot goes down, which is not necessary because we are not doing cone. So make sure the tricot is only in the anterior chamber and then wash it away. So I go and wash it away, that time just depress the wound. So what happens is all the excess tricot actually comes out and only the thing that stains the vitreous will be visible. So that's the technique I follow, but if there are anything else.
Yeah, I think you covered most of it. One thing for a beginner is, before you start a vitrectomy from the side ports, suture your main wound. If you forget to suture your main wound, you're in big trouble. Because the moment the vitreous starts getting hydrated, it'll have to find an easy way out. And the easy way out is through your main wound. So you will have a peaking of the vitreous from the main wound. So before you make in your side ports or you do your anterior segment vitrectomy, suture the wound, number one. Number two, what I do is I just take 0.2 in a tuberculin syringe, the tricot 1 mg, and I take it to full 1 ml. That's approximately 5 times the dilution, and just inject 0.1 ml or 0.2 ml into the anterior chamber. That does the job.
So take home message is every anterior segment surgeon should know anterior vitrectomy. If you don't know, you should learn. We are doing SSCC courses regularly where we are teaching anterior vitrectomy. So anterior vitrectomy is very easy. It can be done from anterior segment surgeon by anteriorly, not we go to posteriorly. Second thing, every surgeon should have a sulcal fixated lens in the library because it is very helpful. Third thing, as they told us, never panic. Whenever there is a problem, you always wait and then keep your whole breath, go out of the OT, go roam around 1 minute and then come back and then do the surgery. So do not panic, manage the case accordingly, and you can have a submersive vision in PCR. There is no doubt about it. So
one point I'd like to add, Dr. Satanshu, which I've trained and I practice myself. In case you have a PC rent, do not come under pressure to put the lens in at the same point if you're not confident on that particular day.
yes.
Do your vitrectomy, close the case, live another day to complete it. Reasons. First reason, Technically, your patient, you tell the patient, yes, I will be putting a lens after 7 to 10 days. Don't worry. You will not see clearly till that time. So that gives the patient a time to get adjusted to a very low vision. So the pressure on the surgeon on the first post-op visit to 6.669 is not there. Number two, your interior and posterior capsules have got a little brittle and hard and rigid, and they start sticking together. Number three, whatever vitreous was agitated is not there in the anterior chamber at all. You've done anterior vitrectomy, it has settled down. And number four, the eye is now much quieter and cleaner. Probably your cornea is better off than what you were struggling to remove the stroma and the nucleus on the first sitting. So I usually, even in a normal clean case, even if I have the lens back up, if my instinct says I can wait and this patient is local patient, he'll come back, I do not push myself or my team to put in the IOL on the same sitting. That is a big takeaway point. So most of my surgeons who were under pressure to put in the IOL would create more mistakes, extend the tear, make more vitreous loss, cause more endothelial trauma. So the moment they started waiting and planning it for the next time, all the results have improved. So never been a pressure, and always tell the patient on the table what has happened, mention it in the discharge slip, and talk to the patient's relative. You do three things, you will realize there's no pressure on it.
And one important thing is, if there is a nucleus part is there, do not try to get it out of the vectis. Most of us, due to under pressure, try to get it out vectis. Avoid it. Let it go down. Close the wound clearly, clean the wound, and send it to your retinal surgeon. He can manage it very carefully. So we should not, in a panic, try to take out with nucleus, because it will come out the vitreous also and will cause detachment also. So thank you very much for all of us for attending our session. I hope it has been very useful to you. Thank you very much.
Thank you.